Okay, so we're recording the event in any case. Baruchim Abayim, a big warm welcome to all our guests tonight. Before we begin, I would just like to run with you. If someone, I will unmute everyone again. Do we hear music? Is someone playing music somewhere? Okay, we've got a bit of a technical issue. We'll fix that.
That seems okay, Jay.
Yes, it seems fine. Yes, so we will go back to where we were and make sure it is recording still. Before I begin, I would just like to run with you the order of the evening and some technical tips on how to make the best of it. My name is Jay Charara. I'm the Vice Chair of the Manchester Jewish Representative Council, and I will be your chair for this evening. You've probably noticed that everyone is muted at the moment. Please stay muted, as sound is very sensitive on these microphones. And if you wish to make a comment or ask a question, please do so on the chat function. Our guest speakers, when invited to speak, will need to unmute themselves. The event will be recorded and a public record made available to everyone who wants it and who wasn't able to be with us tonight. But before I start, I would just like to set the scene for our audience. A full lockdown is currently in place nationwide, as well as continuing restrictions on households mixing together in the Greater Manchester area and districts. Schools and other places of worship are open for prayer within the guidelines, and shops selling essential items are adhering to the rules and guidance in general. Vaccines are being rolled out, with the most vulnerable being considered first. We know that it is imperative to emphasize that the following rules are followed rigorously to speed up the reduction of the infections until all of us in the community are vaccinated. Currently, around 40,000 people have been vaccinated in the Manchester area, including from the most vulnerable cohorts, 1 to 4. With the aim of vaccinating around 800,000 people altogether by mid-April. But before we start, just a quick non-scientific survey. And the question is, are you likely to have the vaccine when offered? So if you could just wave or type yes in the chat function, so we get an indication. Just give you a few seconds so we get an indication as to the level of agreement there. Okay, so quite a few there. Thank you. Dear audience, we are outstandingly lucky to have with us this evening a distinguished guest, Professor Alan Silman, our keynote speaker, who will elucidate for us the benefits of vaccinations and answer your questions. We also have with us Dr. Adam Schogger, that most of you know as the local Salford GP at the Dr. Davis Surgery, Newbury Green medical practice, and Lance Gardner, MBE, Chief Executive of Salford Primary Care Together, who will be quite happy to answer your questions on local provisions. I would introduce our main speaker, Professor Silman, who will give a presentation on the vaccinations and take your questions. We will also have a Q&A with Dr. Schogger and Lance Gardner, and Dr. Jackie Lewis, who is the chair of the Salford Healthy Communities, will make some concluding remarks and give a vote of thanks at the end. We aim to finish around 10 o'clock. Professor Alan Silman doesn't need any introductions. He has been our guest before in the past and very popular. But I will say a few words. Following graduating as a doctor, he trained in rheumatology. Alan then trained in epidemiology at the London School of Hygiene, working with, amongst others, Professor Michael Marmot. He then took up an academic role in the Department of Epidemiology at the London Hospital. He was appointed as Director of Arthritis Research UK at the Manchester University in 1988, as well as a consultant in rheumatology at MRI. In 2007, he changed role and became the first medical director of Arthritis Research UK charity. In 2015, he left AR UK to return to academic research in epidemiology and took up the role of Professor of Musculoskeletal Health at Oxford University. He has written numerous books and over 500 scientific articles. Amongst his current roles, he is serving on the national panel reviewing the quality of epidemiological research in UK universities as part of the government research evaluation framework. Professor, the floor is yours.
Well, thank you, and thank you very much for inviting me in probably the most challenging time in public health that I've faced in my professional lifetime. What I want to do this evening is probably talk for around about 30 minutes to summarize as far as I can the current knowledge we have about the vaccines that are now available to prevent the occurrence and spread of COVID-19. I hope I will cover as many of your questions as you have, but certainly I will be prepared to answer any of them afterwards. So I want to start off by making a very important point, which others have made, that this is a disease that spreads from person to person. It doesn't spread in the drinking water. It doesn't spread through rotting food. It doesn't spread from animals. It doesn't spread by hanging around in the air. It is spread from person to person. If we can stop that spread, we can stop that disease. In theory, if all of us were to incarcerate ourselves in our own homes with enough food and supplies to last for a few weeks and nobody left or went out anywhere, in theory, that infection could disappear. And indeed, there are examples of infectious diseases where strict policies of isolation have been very successful. Some of you will remember reading in the news about the horrors of the Ebola virus pandemic that affected countries in West Africa. There was no successful vaccine at the beginning to combat that infection. And by isolating everybody who got the disease, and for people being very, very strict about not being in contact with others, in a disease that was 50, 80% fatal in people who caught it, we're able to achieve control. And indeed, that was one of the hopes in this pandemic. When I was giving talks about how this COVID pandemic was going to come to an end in March, April, May last year, I, like many others, believed it might be possible to control this pandemic by some of the measures we've talked about. You all know about hands, face, space, track and trace, quarantine, etc., etc. This virus has proved an implacable enemy. And it has proved that provided there are still some people present in the community with the infection, unless we are prepared to undergo the kind of stringent isolation that can only happen in authoritarian states such as China, all the lockdown measures, all the quarantine, all the preventive measures that we have proved themselves to have only a limited capacity to reduce the level of infection. At its peak in the United Kingdom, around the turn of the year, we were seeing around 60,000 new diagnosed cases a day in Britain. A phenomenal rate, a phenomenal rate. Multiplied up, that's 500,000 a week. That's 25 million a year. That was staggering. The rate has now come down, and today, I think it was shortly over 20,000. But of course, that has happened because we have agreed to restrict ourselves to a level never ever been achieved before in peacetime. And thus, and if we show any relaxation in these strict rules, as we know from the 2 previous waves, and as people will know, for example, what's happening in Israel, any relaxation in the strict rules and this virus will continue to spread at unprecedented rates. The fact that the rate has come down in the past month is not a surprise. I would have been devastated if it had not happened. It had to happen, but it has not gone away. We do not have any successful treatment that works when people get this infection to stop them getting sick. We have some treatments that are useful in the sickest in our community, such that the death rates in intensive care, which were 60 to 70%, are about half. But we cannot rely on a simple pill, a simple tablet that we could take when we first have a positive swab test or in contact with somebody, like an antibiotic that will treat and get rid of this infection. So from the beginning, people said we needed to develop vaccines because we may need them. And as it's turned out, it's not we may need them, we absolutely need them. Without vaccines, there is no way that this pandemic is going to come to an end and normal life will resume. Now, when the people started making vaccines, there was no guarantee that they would work. There are many diseases we are still struggling to find vaccines that work. We also know that for some conditions like influenza, flu, We can have a vaccine that works, but maybe in about 60% of the population. But come the next year, that vaccine does not work. One of the great medical success stories of, I was going to say this century, but maybe this century and last century, is the ability of scientists worldwide to produce a number of vaccines that have been shown to be safe and effective within a time scale that a generation before people could have only dreamt about. It is almost unbelievable that within a very short time of the Chinese releasing the genetic code of the vaccine, that research laboratories around the world came up with the design of a vaccine. It was then tested to show that it would produce an immunity potentially in the laboratory. Then it produced some immunity in blood tests in patients. And at the end of last year, 3 vaccines showed unambiguously that they could stop enough people getting sick with this condition, if you like, to take the sting out of this pandemic. Now, before talking about the vaccine specifically, I want to make 2 other points. The first point is that the other way traditionally we become immune to diseases is not through vaccines, but is in acquiring the infection naturally, and hopefully, possibly, acquiring the infection naturally without being ill. I can tell you that pretty well everybody in this audience will probably have antibodies to diseases such as chickenpox and measles, either because they had the infection naturally as a child, which you may not remember, or you were in contact with it, developed antibodies without knowing that you were ill. That is also true, my friends, to the same extent for COVID-19. There are a large number of people, maybe in places like Manchester, it could be 10 to 15%, who have natural immunity to COVID-19, either because they've been ill and were badly ill, or they were ill and had mild condition, or you didn't even know you were ill. And particularly amongst younger people, amongst children, amongst young adults who have the same rates of catching the condition, they might have become immune without being ill. However, what we are learning about the natural immunity from this virus is that firstly, it might not last very long. At the moment, we don't have, obviously, more data than the period of time that we've had an observation for. But we're not sure that this immunity will last longer than 6 months. We also know that if you have acquired the immunity and have not been very ill, or you have acquired the immunity without being ill at all, that level of immunity is also probably not very strong. We have also learned that the immunity that the vaccines can produce is much stronger than the immunity you can get from the natural condition. That is not true for all virus diseases, but it seems to be true for COVID-19. And therefore, the second point I want to mention is that we cannot rely on the natural immunity to give us the protection that we might have hoped. My third point is in relation to this phenomenon that a number of you will have heard about, which is called herd immunity. I have said that this is a virus that spreads from person to person. if there is nobody that the virus can spread its evil infection to, then it will essentially just turn over and die. So one of the reasons that we want to be vaccinated is to protect ourselves. The other reason I believe we need to take seriously our societal responsibility to be vaccinated is that if we are vaccinated and do not become ill, we are protecting the people around us. And indeed, if we can achieve a high level of immunity, we can stop this virus in its tracks. I believe also that this is going to require immunization, vaccination, not only of those who are most vulnerable, but even those who are the least vulnerable, including our children, our grandchildren, our young adults, because we need the large, very large proportion of the population to be protected to stop this disease in its track. So I would just like to say a few words about the vaccines themselves. There are probably 250 different vaccines at different stages in development. You will all be aware that there are now 3 vaccines in use throughout the world. 2 are work by giving a little bit of a genetic code to the body, and the body then produces the bit of protein, which is the nasty bit of the protein called the spike protein, which sticks onto the surface of the cells and makes us ill. So without giving anything like a whole virus, these 2 vaccines, the Pfizer vaccine and the Moderna vaccine, allow the body to produce an immune response against that nasty bit of the virus when it sees it, because it's produced antibodies to the vaccine. The AstraZeneca vaccine is a vaccine which takes a very, very harmless virus that we all have and bolts onto it the genetic instructions to make that same spike protein. We give the vaccine, the body produces antibodies against the spike protein. When the real virus comes along, those antibodies see the spike protein on the real virus and attack it. So these vaccines work in a very similar way. The results of the vaccine trials that came out in December from these 3 vaccines showed that they were capable of reducing the number of people with a significant infection. By that, I mean an infection that wasn't just a mild attack of flu, but caused you to be admitted to hospital, for example, by well over 80% and probably much nearer 90%. In the world of vaccines, these are very high success rates. The other important thing to mention about these vaccines is that they are very safe. A company can produce as much vaccine as it likes. Governments in Western countries can put as much investment into vaccine production, can come into Downing Street press conferences and the like and say, we have got exciting vaccines and we are going to introduce them. But before any vaccine can be introduced in the United Kingdom, in Europe, in the United States, the regulators, the people who act on our behalf, look primarily at the safety of the vaccines. That is their first concern. They will not take, and they have not taken, any shortcuts in evaluating the safety of the vaccines. How do I know it? because for 12 years, I sat on the committee in the UK at the MHRA, the Medicinal and Health Regulatory Agency, and I have been there when these discussions are made. I do not believe any shortcuts were made in looking at the safety of these vaccines. And indeed, as the latest data show, 5 million people in this country have had these vaccines. And believe me, if there were any significant safety concerns in the short term, we would have known about them. Now, clearly somebody's going to say, well, what could happen after 1 month or 3 months or 6 months or 9 months? Well, the answer is we don't know. From first principles, knowing how these vaccines work, I would be extremely surprised, but I can't know. But what I do know is in the short term, these vaccines are very safe. The next question people say, well, do they work? And we are bombarded on the news every day by figures that are worrying, superficially. And I want to say 3 things. Firstly, there has been this debate about 1 dose, whether we should have a gap of 3 weeks, 3 months, or what have you. I think the point to emphasize is that this vaccine, like many other vaccines, and you will all know that most childhood illnesses require at least 2, sometimes 3 doses of a vaccine to achieve immunity. You are vaccinated, you are protected against this infection when you have completed the course. You are not protected when you're halfway through the course, as with so many other things. You need to complete the course to get through the exam. The studies that have been done on the vaccines have reported on the success rate 1 week after 2nd dose of the vaccine. We do not expect, we would not expect these vaccines to work after 1 dose. I have to tell you, there are people who are trying to develop vaccines that work after 1 dose, and that would be wonderful if they do. At the moment, you are vaccinated, you can consider yourself to be properly vaccinated 1 week after your 2nd dose. The second thing I want to say relates to the interval. This is confusing, and I apologize in a way, although I don't take the blame, for the confusion in the messages. All 3 vaccines that are currently licensed believed that you would get the maximum immunity from around about a month gap between 2 doses, not after 2 days, not after 2 weeks, but between 3 weeks and a month. And indeed, the first 2 vaccines, the Moderna and the Pfizer I talked about, they showed that that 3 weeks was the right interval and you achieved high success rate. The AstraZeneca vaccine was interesting. They wanted to look at 1 month, but when they did their studies, because of supply problems, and they were doing their studies in Brazil and in South Africa, they struggled to get the vaccines for the trial. So a number of people actually had to wait 11, 12 weeks between doses. And what AstraZeneca showed, the AstraZeneca vaccine, was that the longer they waited within that interval, up to about 11 weeks, the stronger the response. And that is not unusual given what we know about vaccines. So it made a lot of sense for the regulators for the AstraZeneca vaccine to say, look, people aren't vaccinated until after your 2nd dose. We know that it works best after a gap of 3 months. Please have the vaccine, but be patient and await 3 months. Now, the Pfizer and Moderna vaccine are very effective after 3 weeks. There is absolutely no reason to believe that that effectiveness will wear off. When you get the second dose after 3 months, there is absolutely no reason to believe that it won't be as effective as if you'd had it within 3 weeks. We can debate the government's decision about whether it was the right thing or the wrong thing, and for at-risk groups, whether they should move to get the dose within 3 weeks. All I wanted to do was to reassure people that waiting 3 months, there are no data that you will suffer. Last 2 points, and then I'll take some questions. You would have needed to have been on a different planet not to have heard the words new variant recently. With the anxiety, in fact, the genuine anxiety that the new variant that came to this country started off in Kent, sometimes called the Kent variant, is associated with a much more rapid rate of transmission. And there are a number of reasons why that is so. That basically, if you have the Kent variant of the virus, which is probably the main variant that's affecting most people now, at the moment, what we know is that this virus grows much quicker. And when you cough or sneeze or what have you, if you have that new variant, you are probably coughing out, sneezing out, shouting out, laughing out, more copies, and therefore more people get infected. And that's why we have seen the numbers go up. The news, one of the briefings last week, was possibly this variant might be associated with more severe disease. I have to tell you, that was not based on real data. That was based on some statisticians putting into their computer models, making some inferences about how this variant may work. At the moment, we do not know whether this variant causes more serious disease. What we do know is that the current vaccines work against this new variant. The current vaccines work against this new variant. Now, I would have stopped this talk here, but yesterday, and some of you may have read it, on the news, there was a discussion about some of the other variants, particularly the so-called Brazilian variant. Now, it does appear that the vaccine produced by Moderna, and if this is true for the vaccine produced by Moderna, I would confidently expect it to be true for the other vaccines, does actually produce an antibody response against this Brazilian variant. The amount of antibodies it produces against that variant are not as high against what this vaccine produces against other variants, but the people who've done the research believe that they are high enough. So at the moment, we have very good reason to believe that none of the variants, as nasty as they are in spreading the disease, will not respond to the current vaccines. The other good news story is that the way that these vaccines have been developed means that they can be developed and refined very, very quickly in a matter of weeks. So if it turns out, and that's a big if it turns out not these variants, but in a week or a month or 6 months, that there are some variants for whom these vaccines are not as good as they should be, it will be a really relatively simple job for the vaccine manufacturers to tweak their vaccine design to produce the vaccines that we need. Indeed, what Moderna company said yesterday, and that made sense, it might be that what we might do is might even need a 3rd dose after a month or 2 months or 6 months or what have you. And I suspect we will move to the situation where, like flu is within our communities on a, if you like, a permanent basis, and every year those who are most vulnerable have a top up. I believe moving forward, it is quite likely that maybe every year, possibly every 6 months, we might need to have a top-up vaccine. But I do believe that it will work. And the final thing I want to say, Jay, if that's okay.
That's fine, please go ahead.
Yeah, is that going back to the beginning, if you remember, I said this is a virus that works from person to person spread. Stop communicating with other people and this virus will stop. Being vaccinated with our successful vaccines, we have a very high chance, particularly if we have very high rates, that it can stop. Put those two together, put those two weapons together in combination, that is unbeatable. And in the period of time leading up to that point where we've achieved enough people being immunized, we are going to need to work with both those weapons, reducing our person-to-person contact so the virus has nowhere to go. And if it ends up having somewhere to go, the vaccine stops it in its track. And maybe with that, Jay, I'll pause and take any questions people have.
Yes, certainly. Thank you very much for that, Professor. Yes, certainly the question of prevention and control is a very important one. I was in a meeting just this week with the Director of Public Health in Manchester, and one of the areas that was covered was the fact that the plan was to have everyone vaccinated by perhaps September. And as you said, maybe there is a need to look at this on a yearly basis in a similar fashion to the flu. Now, the question is whether we are vaccinating with Moderna, Pfizer, or with the AstraZeneca. We've seen this recently in the news, do we have enough of the vaccines? Do we have enough? Can we produce enough to keep up with the demand? Because none of us are safe until all of us are safe around the globe.
So I think that's a very good question. Of course, in theory, the world's vaccine capacity production can be geared up to produce enough vaccine for everybody. When we are faced with disasters on this scale, the world can respond. What I should tell you is that producing a vaccine is not the same as producing a factory that manufactures baked beans or produces T-shirts. The requirements, the stringency that goes into producing a biological product necessitates an incredible complexity in regards to the infrastructure that's needed. We all want to be assured that every single batch of vaccine is safe. That I was aware on my time MHRA how important it is not to say just because this factory, the production plant is up and running, that we've got the policies and the procedures and the quality assurance in place that each dose of vaccine is as good as the previous one. And this takes time. I think 5 years ago, it might have taken 3 years to commission a vaccine production plant. Now we're seeing that in months. We just have to be patient. And of course, we started off with 250 vaccines on the starting block. There was no way that we could invest globally in mass producing all those vaccines because we didn't know which ones were going to work. Some of you will be aware that a Chinese vaccine that was one of the first off the blocks, which was actually made in the traditional way of using a weakened version of the original virus, has turned out not to be that effective. So it would have been, in a way, ridiculous to have put all our eggs in that basket. So while I'm saying I recognize at the moment we are not going to have all the vaccines available now when we want them, I believe moving forward, the world will have developed the capacity that year on year that will be ramped up, that will not be a problem.
Please God, it happens very soon, and that we're all safe. Another question that we had here was, you know, if we put ourselves in the shoes of, say, someone who's expecting and so on, there are anxieties associated with that. We know that in the past there were issues with vaccines generally, and I'm thinking in particular of MMR and autism. Now, how do we deal with that? How do we view it in respect of the current vaccination program that we have, that in 20 years' time, we're fine?
So let me be absolutely clear. There is no link between autism and MMR vaccine. The claim that was made has proved to be a falsehood. The doctor that made the claim lost his license to practice in Britain, and he has been completely discredited. There has been an enormous amount of research wasted in many ways because of that false criminal claim showing there is no evidence MMR causes autism, period. We don't even need to debate that. I would put my house on that. I think the other thing to say is that the vaccines that have been developed for COVID-19 do not contain the whole virus. Many vaccines that have been used for other diseases in the past, including things like rubella and mumps and measles, etc., did actually have the live virus or part of the live virus. These vaccines, so-called RNA and DNA vaccines, we are not giving anything to the body that is capable, as far as we can tell, of causing damage. There has been an incredible amount of safety evaluation. And I have to tell you, this safety evaluation is done in animals, it's done in people, and these days, as you would expect, it's done through the use of computer modeling and artificial intelligence. Yes, people will have some minor reactions, headaches, minor fever. But considering the millions of doses of vaccine that have been produced, the number of side effects is trivial. And let us not forget, compared to the millions of people who've had COVID, and we've learned today that 100,000 people in Britain have died, where this is a completely different ballpark. We can't even mention them in the same breath.
So just going off No, I'm not.
I will mute everyone again and ask the professor to mute himself.
Thank you.
Okay, I'm going to turn to Dr. Jackie Lewis to see if we have any questions there.
Thank you, Jay. Let me just see. In pregnancy, there have been 1 or 2 questions about that, about safety in pregnancy and whether the Pfizer or the AstraZeneca vaccine would be preferable in pregnancy if someone has the choice, and also about safest stage in pregnancy to be vaccinated if someone, for example, is a frontline worker and chooses to be vaccinated while being pregnant.
So thank you for that. So the first thing to say is that probably for very good reasons, when vaccines are tested, they're not tested in people who are pregnant. So to some extent, we are working from expert opinion rather than from data. The trials specifically excluded people who are pregnant because of concerns that there may be unknown problems. However, I will say a few things. Firstly, we know that pregnancy can be an unsafe period for people getting the infection. And there is a concern that particularly people in caring roles, perhaps nurses, care workers, other people in health services, etc., if you are pregnant and catch the virus, because of the generalized reduction in the body's immune system during pregnancy, and that's there for good reason, because the baby to some extent is a foreign, in immune sense, is a foreign person inside the uterus. So you don't want any bad immune problems from the mum to affect the baby. So pregnancy is associated with a period of reduced immunity. So actually it is bad probably for women who are pregnant who get the infection, both in terms of that they could get a worse infection and the possibility, and we're not really sure because there's not enough data, that there may be a potential that there may be more harm to the baby, either reduced birth weight or very unusually, maybe some birth defects, although the numbers are too small. So the advice is that actually for women who are pregnant or thinking about pregnant, against what seems to be a small, it is small, but real risk that if you catch COVID, it could be worse for you and your baby. It is far better for you to be protected with the vaccine. So experts like Anthony Fauci, the person who's advising Joe Biden and is the head of the National Institute of Allergy and Infectious Diseases in the United States, and others are saying, we don't have any theoretical reason to believe it's harmful. Given the potential harm of getting the infection, it is much better that pregnant women are protected.
Thank you, Professor, for that comprehensive answer. We have a question here from Alex Klein. And the question is, does the length between the first and second injection affect the level of protection? And also, if we can add on to that, do all of the vaccines require a first and second injection?
So that's a good question. Thank you for that. As I say, the unfortunate thing is, to some extent, is that we know, as I said in my talk, that the AstraZeneca vaccine, the protection is increased the longer the gap. The Pfizer vaccine and the Moderna vaccine, we don't know because they were only tested with a 3-week gap. And I think Britain and possibly Denmark, although a few, I think Austria maybe, some other countries are moving towards a longer gap. Theoretically, as I have said, I do not envisage that it will reduce the level of immunity, but the immunity is very high. I think that the high level of immunity will be found 3 months to the same extent after 3 weeks. This is a different point. I mean, I think that for people who are frontline care workers in our NHS, and I'm making a political point here and not a medical point, and we want, you know, one of the problems in the NHS at the moment is the nurses are being sick, being ill, or they are having to isolate because somebody they're in contact with or through their kids' school or what have you. Then I think it would have made sense for all frontline workers in the health and care industry to have had the vaccines at 3 weeks, just because they are protected quicker and we need them back at work. The last part of your question, will there be a vaccine that works with 1 dose? Potentially, yes. The Johnson & Johnson company, I've got a clinical trial at the moment comparing 1 dose with 2 doses. They've told us the results are expected any day now. Given the fact that their vaccine is very much like the AstraZeneca vaccine, I'd be surprised if they showed 1 dose was good enough, but they're testing it.
Okay, thank you for that, Professor. I think we've answered most of the questions that we had from our audience, as well as the questions that we had earlier on. Just to wrap up this section.
I wonder, sorry, because somebody's given
yes,
a comment here, and I've seen this advertised, that can I say that this issue that's been circulating on social media, that these vaccines cause infertility, there is absolutely no data to suggest that, and there is no reason why that should be so, either in males or in females.
Thank you for that. Could I just ask one last question? And that is, this is a question for yourself, Professor. Now, this epidemic is an event that happens once every 100 years or so, and no one saw it coming. And from your personal perspective, how did you feel about it when it happened, and what has changed for you? Has anything changed at all?
Yeah, it's a really interesting question, a really good question. When the virus first hit, we knew what was happening in China, but the message was that actually this was just like seasonal flu. And, you know, I'm aware, having worked as a junior doctor in the NHS, that during a bad flu epidemic, a lot of elderly people, particularly with underlying chest problems, can end up in hospital, and unfortunately some could succumb. And yes, there was the sense that this could just be like bad flu. What hit me in around about May, June time last year was that and maybe I should have mentioned this, Jay, the reason why this virus is such a lethal enemy is not because of the virus itself. The virus, if you met it in the streets, you'd think, gosh, nice, harmless looking virus, looks like any other virus. For reasons that we're not sure about still, although some of the evidence is becoming clear, in some people, and sadly that some is quite a lot, maybe 15, 20%, the body, our bodies, treat that simple, innocent virus as if it is a major enemy and mount a response in terms of all the different things we can do in combating an infection in a way that's actually harmful. And the reality is that when we hear about people getting really sick in intensive care, for example, and getting blood clots and et cetera, most of that damage is not caused by the virus, but it's caused by the body's overreaction for reasons that we don't fully understand. Some of you will be aware of this drug called dexamethasone, which is now widely used in intensive care. And the dexamethasone doesn't kill the virus. Dexamethasone stops the body overreacting to the virus. And that was my biggest surprise.
Thank you very much, Professor, for your very comprehensive talk tonight. Now we will turn to Dr. Adam Schogger and Lance Gardner. We will ask Dr. Adam Schogger first to give us a few words from a local GP perspective. Dr. Adam Schogger is our local Salford GP at the Dr. Davis surgery in Newbury Green, and Lance Gardner will give us the public health perspective as well. So Dr. Adam Schogger, the floor is yours.
Adam, you need to unmute.
Unmute yourself.
Okay, can you hear me now?
We can hear you, yes, go ahead.
First of all, can I say personally, it's a great pleasure to see Professor Silman again. I'm sure he's not aware of it, but we go back nearly 40 years when he was an epidemiology lecturer at my medical school in the London Hospital. But we both had hair then, and it was black for both of us. And he had a very unusual skill that he made a bunch of 20, 21-year-old people be actually interested in epidemiology, which is quite a mean feat. So it's nice to see us so many years, even though we both got a lot older. So first of all, I saw one question was asked at the very end. I don't know who it was. I think it was Mrs. Nelson, who asked about allergies. There aren't really any contraindications to having the vaccine with allergies. Some vaccines are grown in egg. So those with allergies to egg can't receive the vaccine. But the Pfizer and Moderna vaccine, I think the AstraZeneca one, are not grown in egg. So people who have egg allergies, I think, to fear from this virus. Locally, get lots of questions about the vaccine, some of the questions have been answered already by Professor Silman, but we get lots of the kind of weird ideas that are being expressed. He's mentioned infertility, he mentioned miscarriage. Again, to reiterate what Professor Silman said, there's no evidence that it causes these sort of problems. Also getting some of the questions asking about 5G and microchips and all these kind of really insane conspiracy theories. And that's what they are. They're insane conspiracy theories. There's nothing injected which is harmful or can cause tracking of people or any of this kind of nonsense. The vaccines are being rolled out in Salford. I'll leave it to actually my boss, Lance Gardner, to talk about things, how he is organising the rollout of the vaccine, organising the testing, all that kind of thing on a local level, and what is being done. But there are certain things which GPs are doing as well. In our practice, we aren't vaccinating. Within the practice, it's going to be done in a local hub, which is still yet to be set up. We will be doing fairly soon. We're starting to do vaccinations for people at home, and that hasn't quite been organised yet. Certainly in the old age homes, and I don't know about the Fed and Heathlands, because it's out of my area, but a Beanstalk home, which is just down the road from our surgery, they have received the vaccine from a different body, from the care homes practice, and they have been receiving the vaccinations. And then not really much to say from our end. I know that one of the last questions to Professor Silman is how his work has changed. since the vaccine. Our work has changed, and all GPs are the same, has changed radically. In that most of our work now is being done over telephone or with email pictures. Some GP surgeons have video conferencing facilities to do consultations in that way, but we're all doing far less face-to-face consultations. Some GPs I know in Salford aren't doing any consultations face-to-face. This, I think, is not a good thing. I think we need to see some patients which you cannot evaluate by video or over the phone, who actually need examination. And certainly in our surgery, I know that all the GPs in Newbury Place, the three practices there, are all bringing in patients as and when they're thought to be necessary. Any other questions that you want to ask general practice before going to Lance?
Thank you for that. We had some questions that were there earlier. One of which is, are the local rabbinate broadly supportive of the vaccination program, and are most people accepting of the vaccine offer?
Yes, most people are quite keen on it. There are some people who are anti-vax altogether. We have a problem with immunizations of babies. We have quite a few people who come in are anti-vaccinations in the main, and also COVID. I think the COVID one is, funny enough, less opposed in the community because it's all the news. Everyone's talking about COVID, and everyone sadly knows somebody who has been nifta, who's passed away in the community, including some very important Rabbanim as well, and in London too. And I just saw in Hamodia last Friday night, a letter was printed. I'll just read it out to you. It's the London Rabbanim, are still most of them are famous. And it was, read as follows, dated 24th of December. Dear community members, Halakha, Jewish law, obligates us to care for our health and the health of those around us. We therefore strongly urge those eligible to access the COVID-19 vaccine and to do so upon the advice of their GP and or personal physician. And this was signed by Harav Bixenspanner, Harav Brief, Diane David, Diane Gelly, Harav Haga, Harav Hamer, Harav Portal, Harav Sabag, Harav Tugendhaft, Harav Birnbaum, Diane Cohen, Diane Dunner, Harav Greenberg, Harav Halberstadt, Harav Rappaport, Diane Simons, Harav Zimmerman. So these are all very important leading figures in Anglo-Jewish Haredi population. Locally, I know that this Thursday, in the start of the day, the Torah Way, there's a speech which is entitled, what do I do if I have to get my COVID vaccine on Shabbat? And that means that they're going to take the COVID vaccine, a bit of Talmudic Bilpul. That means they're accepting the vaccine. But the question is what you should do on Shabbat. So I think there is a general push, a general acquiescence and encouragement to have the vaccine in the local from community.
So thank you for that, Doctor. I know the question regarding Shabbat, and there is Pikuach Nefesh that is precisely for Shabbat. I also know that Hatzolah do a lot of work around here in Broughton Park and elsewhere. And the question is, how soon might the GPs reach the housebound elderly to vaccinate them around where we are, Broughton Park area?
Yes, it shouldn't be too long now. Again, Lance will be able to answer that more directly, but we received emails this week to start that process, and it will be happening really in the next couple of weeks, if less, in the next 10 days, to start homebound patients being vaccinated, at least the first vaccine.
That is really good to hear. And someone, in fact, I'm going to turn to Dr. Jackie Lewis to see if there are any questions there on the chat function for Dr. Schogger.
At the moment, none have come in specifically about general practice.
Okay.
But I wonder if anybody from the audience wants to add any questions. Though I can see, sorry, there is one about children in school. And with that previously, there had been the question about how soon is it likely for young people with severe learning disability, are they going to be counted within the high-risk category at all?
I don't know, that takes the level higher than poor infantry like myself. But I think anybody with a disease learning difficulties, I'm not sure, Professor Silman might be able to correct me on this, I'm not sure if they fall in a vulnerable capacity or group necessarily, but certainly those with coexistent morbidities, other illnesses, asthma, COPD, diabetes, they're going to be higher up in the queue. But at the moment, it's still going to be by age. First line medical professionals, and myself, I've had one vaccine. I know dentists have received vaccines, nurses are receiving vaccines. They're being pushed a little bit ahead. I saw somebody ask questions about teachers. That's not a question which I can answer. That's a political decision, which I don't have any information about.
Thank you for that. Another question that came through regards to the fact that we have this vaccination program going on, but we're still not out of the woods yet. The virus is still out there, and as the professor says earlier, we still need to keep our distance, wash our hands, and adhere to all those rules. Generally speaking, from your viewpoint, are people still keeping and achieving good social distancing?
Well, it depends. If you look at the papers from last Thursday, you look at the answers being no. I think the majority of people are being quite careful. There are quite a lot of recidivists, however. I've stopped going, but I was going to a certain major synagogue, and out of 70 people actually in the room, only one was wearing a mask, and that was me. So it has been pretty bad. I haven't been since the summer because I stopped going, but it is difficult. I think a lot of people are ignoring these things. I saw pictures from Stamford Hill on WhatsApp yesterday, going to supermarkets and not taking any precautions at all. The local shops are being fairly good. I think all of them, I don't want to name names, but the ones I've been to have all got hand sanitizers at the door, or notes saying, you know, wear masks. So I think they are encouraging these sort of things. Well, it's 100%, sadly not. I think there's many people who aren't doing these things. During the lockdown, there are lots of illegal street minyanim, and this was sad. I know a colleague of mine, she went for a walk on Shabbat morning, and she saw lots of people walking into alleyways having illicit minyanim. I mean, this is regrettable, to say the least. Yes. But by and large, I think most people are keeping it.
I was going to say that, Doctor, that by and large, the majority of people are adhering to the rules and are following them, and like everywhere else, when we look at a normal population, there are always those that are going to be either side of the bell curve, as it were. Well, that is very, very useful. Thank you very much, Doctor. Are there any questions? Yes.
Yeah, is it possible to ask a question?
Certainly, go ahead.
Thank you. Okay, so basically, in 2010, there was the swine flu epidemic. I have a personal account where a family member of mine got the Pandromex vaccine, and she developed narcolepsy. If you look on the Narcolepsy UK website, it says that basically in 2010, there was a startling increase in narcolepsy. I just want to know, considering that we don't know the long-term effects of the vaccine, would you consider people who are not in the vulnerable group to also go ahead and get the vaccine? Or do you think maybe that they should wait because there could be side effects that we do not know of because there are no long-term studies?
Okay, who is this question for? Are we asking the GP?
Well, I mean, if you
any
want...
of the doctors or anyone that feels that they're qualified.
And if you want, I feel incredibly qualified to talk about this because I was involved in reviewing the data about narcolepsy and pandemrix. It is actually a very, very complicated issue. And although there was a court case which settled, the nature of the data I found as an epidemiologist was relatively weak. and it was quite interesting that in terms of what the scientists believed was the strength of the link, it was weak. And one of the problems about that, the issue with narcolepsy, and I don't want to take over this forum on that, is that the vaccine stopped being used relatively quickly because it turned out that swine flu wasn't the big issue that it was going to be. And then we were unable to do the kinds of studies where we had vaccinated and unvaccinated group with people who were unaware of the risks. And narcolepsy is one of those interesting conditions where people fall asleep, where even the doctors who treat it can't agree on what constitutes a case. And so one of the issues that emerged was that, were there more cases of narcolepsy following the vaccine because more cases were reported because of the concerns that had been expressed in the media. But the other thing, again, is worth mentioning. These vaccines being used in this pandemic are different because they are not live virus, pathological virus vaccines. They are completely new ways of developing vaccines. And I think for that reason, we need to be optimistic they're going to be very safe.
Thank you. Thank you very much.
Thank you. So I appreciate that. I just wonder if you could address the question.
So, okay, can we just leave it there? Thank you. And so because we're pressed for time, so we're going to move on now. Thank you. What I was going to say is that scientific research is paramount, and it's built on the validity and the reliability of the research, and it's always ongoing, and there's always further research and peer reviews and so on and so forth to approximate the real answers and the real truths. Now I know that we have Lance Gardner with us as well, so I will give the floor to Lance Gardner, who will tell us a little bit about the primary care point of view with regards to vaccinations. The floor is yours.
Thank you, Chair. I'd like to say what an honour it is to be able to come to such an august body and a really interesting discussion. Can I just answer a couple of questions that didn't get answered? So the lady who asked about children and teachers, the vaccine is not licensed for children under 16. Pfizer is licensed at 16, AstraZeneca at 18. So that's why the school children aren't being done. And Professor Silman will tell you much better than I that the risks amongst children are minimal. And that's one of the reasons why they haven't tested to that degree. The other thing is that government, for whatever reason, I know it has been debated long, that school teachers are not in the priority groups. Whether we agree with that's a different conversation, but they have agreed it is not a priority group. So I just thought I'd answer that. And no, you can't choose which vaccine you get, and I'll come on to why. So I'm Lance Gardner. I am the Chief Executive of Salford Primary Care Together. We're the organisation that supports GPs throughout the city. Well, we did pre-COVID, now we do lots of other things, and one of which is I am now the Senior Responsible Officer for the vaccination programme for the whole city. Anything that is not done in hospital, vaccination or COVID-wise, falls under my remit. So we've been providing COVID services since the COVID vaccination services since the 18th of December, and and when the NHS sets up, they set out. We are under what's called command and control. So I have worked in the NHS for 40 odd years. I have never, ever known the NHS tell me what colour underwear to wear or what colour socks to wear. But at the moment they are. So what they did is they stipulated what a building had to look like to be able to give the Pfizer vaccine. And I mean, how many square feet, how many toilets, how many doors, how many car parking spaces, whatever. There is nowhere in your community that meets those criteria. We have looked, we've been in 30 odd buildings. So the Pfizer centres at the moment are at Clarendon Leisure Centre, Eccles Leisure Centre and Earlham Leisure Centre. And that's because we can deliver Pfizer vaccine really well, and it meets all the criteria. I'm sure you're all aware the Pfizer vaccine, and the professor knows this better than me, but it's a very volatile vaccine. It has to be stored really carefully. It has to be administered really carefully. It's really quite unusual for a vaccine. And so we have a whole set of procedures. So what we've done is we've created super vaccination centres at Clarendon, Eccles and Earlham. And we are now, and initially we were slow, but now we are giving up to 1,000 a day in each of those centres. So we're doing between 1,700 and 2,000 vaccines a day every day, as long as we've got vaccine. And that's the tricky bit about whether you get choice or not. So the professor will tell you having a choice makes no difference. I'm hoping he's nodding, good. And you do well to get whatever's available. And I can only give you what I am sent. So I can't order vaccine. I don't put in an order and they send me AstraZeneca or they send me Pfizer. I get told what I will get. And I have to work with whatever is available to me. So if you turn up to our centre, you'll see a big sign on the wall and it will tell you that today we're doing Pfizer. And I've forgotten who it was, it may have been Mrs. Jacobs, said you need to have a choice. And you do have a choice. At that point, you can leave because we haven't got any AstraZeneca. If we're doing Pfizer that day, we're doing Pfizer. And the way the Pfizer works is, as I said, it's a difficult vaccine. So when it arrives with me, I've got 3.5 days or 84 hours to use it, all of it. And that is 1,000 vaccines. If I don't use those 1,000 vaccines in those hours, 80 odd hours, I have to throw it away. So I can't use it after that time. And we have a clock on the wall, you would see that we have a big clock on the wall. And once we get to that time, we have to throw it away. So be just mindful of that when we're talking about vaccination. AstraZeneca is for us as vaccinators a game changer because it's much more mobile, it's much more dynamic, it's a much more versatile tool for us to use. But we've only had it in town for a fortnight. And we put all of our AstraZeneca into our care homes. So the good news is the government set us a target of getting everybody who is resident in a care home vaccinated by the 24th of January. We got them all done by the 22nd. I don't know about the Fed because the Fed's not in my boundary, but I'm knowing the Fed will have got them done. Good news, question somebody asked earlier, is we start the housebound with your GPs on Thursday. Now, please do not leave this call and go off and tell everybody relatives, friends, neighbours who are housebound that we're coming on Thursday. We've got a few to get through. We're not going to get them all done in a day. So can we just manage some expectations? So it will take us a couple of weeks, but we're coming from Thursday, and I know because I'm doing them. The other thing we are setting up, as Dr. Schogger said, is we are creating a community facility for you from next week. And we are just looking, we're looking at whether we can manage it in Newbury Green, or we need to use Broughton Hub, or we need to use some other facilities. But we're looking at those tomorrow, and we will make a decision this week. So we will have a facility in your community, or very close to it, by the end of next week. And we are now, as some of you have been saying on the messaging, we are now inviting virtually everybody over 70 and the people who are clinically extremely vulnerable. So we're starting to work our way through all those groups. And we've done, I'm proud to say, we've done 10% of the population of Salford already. So, and we've only had vaccination really going for a couple of weeks. So that's not bad going. And the majority of those, vast majority, 90% of those are over 80, and they're the people who are at greatest risk. I'm going to stop now and let you ask me questions about the practicalities of the programme.
Thanks, that's really, really useful. And I'm sure I speak on everyone's behalf when I say that a lot of people have been taking notes and listening to every word that you said, because we have a very local or a very local community here. And when you do say that you're looking at places like Newbury Green and elsewhere as hubs, that really is very useful. There was something that was mentioned earlier on, and that reminded me of other issues that we've heard recently and also in the news. And that is when there is spare capacity, because some of the vaccines, such as the Pfizer and so on, have to be stored and under certain temperatures and what have you, and have to be used by a certain time. Now, if there are spare, as you said, and the clock is ticking, now what happens there?
So that's a brilliant question. So what we do is we have a cohort of people, and when we've got the clock ticking, we have them waiting outside just in case. So when we're getting down to that final hour of the time I've got where the Pfizer is doable, we have some people around, and we do try and tie it up really tight. But we will, we might know that we've definitely got 20 spare, but if people don't come, we might have 30. So we might have 30 or 40 people hanging around outside, and we pull them in quick and we get them done. So it is really as daft as it sounds. That is how we do it. The other people, and we've done that with some of your community. So we've done that with some of, we've been talking to the ambulance people. I'm sorry, I don't always understand the words. So and the doulas. So we've been working with the doulas to make sure they get done. So we've been working with your community through Dr. Schogger and others to make sure that we get the groups who the NHS in its more traditional sense might not recognise as are really, really important in your community. And we're getting through those and we're getting them done as fast as we can. So yes, we...
Okay. Thank you very much for that, Doctor. One last question, and that is from Rabbi Saunders. I'm going to ask Rabbi Saunders to unmute himself and ask the question himself.
About what? He's asking you a
question.
Hi.
Hi, thanks. Yeah, can you hear me? Yeah, hi, Lan. Yeah, as I've been vaccinated with the AstraZeneca through the care homes. I just wonder, firstly, they do ask questions about allergies and so on and past history. Are there some people who would be better off with one over the other, even if you...
Arnie!
Can you please mute? Can TY mute, please?
Can you hear me?
Yes, carry on, Rabbi.
Yes, sorry. Are there any allergies that would make it better to have one rather than the other? And while I've got the floor, I didn't put this in the chat. I hear all sorts of people talk about, all the anti-vax theories, although in my experience, the vast majority of the people who've been called so far from the community, from the Haredi community, the over 80s care homes, the vast majority have taken. In fact, I haven't heard of anyone actively refusing. That might happen as we get down the cohorts where people will say, well, I'd rather not. I'm not so vulnerable. But what you do hear, and some of the anti-vax stuff is completely ridiculous, and obviously some of the anti-virus existing stuff is ridiculous. But what you do hear is people who talk about so-called cures. You see adverts in the Jewish advertisers and so on. There was one the other day, somebody was selling something for £150, which was supposed to A, cure you if you had the virus, and B, protect you if you haven't. And I've seen quite a few of those sorts of things. I just wonder if whether the professor or Lance or anybody would like to just say something about that. So that's two questions, if you like. Thanks, and thank you for a wonderful session.
Anyone want to answer that? Lance, do you want to?
The allergy one, the allergy part of that question is, as Dr. Schogger said, it's in the early days when we first started using Pfizer, the list was quite long. But actually, as we've been doing it, you know, and we've now done nearly 6 million people in this country. So we're learning a lot more about this. As the professor said, you're learning about this vaccine every day. We're learning, the country's learning, the scientists are learning. So we're learning what matters. So, and actually, I think in the 30-odd thousand people we've done, I think we've had 6 where we had an allergy issue, a proper allergy issue where we've checked that they were allergic to something that is in the constitution of the vaccine, and we've not been able to do it. Other than that, we haven't. It's very rare, as Dr. Schogger said. Most people, vast majority, can go ahead and get vaccinated, and they're probably safer with the vaccine than they are of getting COVID.
I can add a bit to that. I mean, the data suggests I mean, when people talk about allergy, the thing they're worried about is this thing called anaphylaxis, where people have a catastrophic allergic response. And considering the millions of people who've had it, the number of cases are absolutely tiny. In terms of the vaccines, for those of you interested, I think the 2 things that people have been concerned about, one is called PEG, polyethylene glycol, and the other is called polysorbate, which are kind of the vehicles that are used to carry the vaccines. These are only exceptionally rare. People are only very, very rarely allergic to them. And as far as I'm aware, all the vaccines use one or other of both of those vehicles, but maybe Lance knows.
Thank you very much for that, Professor, and thank you, Lance. I'm sure everyone here tonight will back me up when I say this, that we can go on talking about this for a couple more hours. And unfortunately, we don't have 2 more hours to finish our discussion. So now I'm going to turn to our chair, Dr. Jackie Lewis.
Can I just say one thing?
Yes, go ahead.
There's one thing. There's a very, very important question came up a few minutes ago, which was, I didn't see as it came across. Somebody asked about if they're young and not in the vulnerable groups, should they receive the vaccine? And I think it's absolutely crucial to do so. I think people have to understand what a vaccination program is for, and I hope I don't get told off by my old lecturer. Besides, apart from my old lecturer, is I see my rabbi who did my my wedding as well here, so I'm seeing all of old timers here. As Pope Allen backs me up on this, the point of a vaccination program isn't to confer individual immunity, as far as I look at it. It is in order to get the immunity raised up in the whole community. And the higher that vaccination rate is, the better the population and the country is going to be protected from this epidemic, to stop it in its tracks. So it's not individual immunity trying to achieve, although that's obviously for the individual, that's what's important, but it's trying to raise the number of antibodies or number of antibody positive people within the community to stop this virus in its tracks. So I think it's crucial to have as many people as possible to receive the vaccine, because those who are less likely to be ill are going to lower down the pecking order. But it's still important for as many people as possible to get vaccinated, obviously within the limits of the vaccine guidelines. That's important. I just want to make that point importantly. And also, it's a little bit of good news that I see from Israel, some interesting information that in Kupat Cholim Maccabi, which is one of the healthcare organizations in Israel, there out of 128,000 people so far received the vaccine, only 20 have come up positive for the virus after they started the immunization course. That's 128,000. Of course, it might come in the future, but still, it's a tiny number of people. And also figures released by the Israeli Ministry of Health that the number of admissions to hospital has gone down by 60% since the vaccination program. This is a vaccine which works. All 3 of them work, and I think that's an optimistic thing to mention, to recognise that these things work, and that's why it's so important for compliance or for people to have these vaccines. Such a high uptake is so important because it works, and it's going to be the only way really, as Professor Silman said before, together with hygiene measures, etc., we're going to stop this thing in its tracks. As far as somebody else mentioned about long-term effects, of course, we don't know long-term effects. But I think Prof. Silman mentioned that earlier on, that at least on a theoretical basis, there's no reason to expect real problems in the future.
Thank you for that. Yes, Israel is light years ahead in terms of vaccinations. I think that they're into 16 to 18-year-olds at the moment that are being vaccinated. And B'Ezras Hashem, that we're all vaccinated very soon, and we can go back to some normality. I will now pass on to Dr. Jackie Lewis for her concluding remarks, our chair, and a vote of thanks. Dr.
Thank you, Jay. So firstly, before I round up, can people, as at the beginning, either wave your hands or put in the chat box? We're very much hoping the answer will be yes. When you're offered the vaccine, are you going to accept it? If you can please let us know. So I would really like to thank our wonderful panel so very much. Professor Silman, firstly, for your vast knowledge and your excellent ability to make complex science understandable to everybody. We're just really, really grateful to have your expertise available to our group. And also to Dr. Schogger and to Mr. Gardner for giving the local perspective, and because you are actually there on the front line, giving out the vaccine and helping to protect us all and bringing the end of this pandemic so much closer for us. And we really hope that all our audience will stay well and stay safe. Thank you so much for a fabulous evening, and thank you to our fantastic host tonight, Jay Charara. Thank you, everybody.
Thank you.
Thank you.
And with that, we will conclude the evening. Thank you very much for being here, and goodbye.
Thank you very much.
And nice to see you again, Adam.
Yeah, okay, thank you.